and that kind of stunts the description of an essential service.
Mm-hmm.
And realistically, EMS is a public good, right? It's non-exclusionary.
This episode of the Overrun podcast is brought to you by Team Life. Your hands can save a life. Learning how to perform high-quality CPR can be the difference for someone experiencing cardiac arrest. Team Life offers CPR certification classes throughout New Jersey taught by trained professionals. Sign up today for CPR certification classes at teamlife.com and learn the skills necessary to save a life. Anyone can be a hero. Now back to the show.
Hey everybody, welcome back to the Overrun. My name's Dan Schwester. I'm also taking over for Ed today. He is actually on the road. So we actually have a really cool episode planned out for today. I'm sitting here with Dan Gerard, who is a senior medic. He has been around a long time. If you have been to one of the major conferences, you've probably seen him talk. You've probably heard him. Dan, welcome to the show. We're going to talk about a couple things that I think are really important. Just say hi to the gang and tell them a little bit about yourself.
Hi. So, I got my start. I got my EMT card in 1981, and I got my paramedic card in 1985. I had the honor and the pleasure of working in Newark, New Jersey, but I worked all over. I worked in Jersey City. I worked for St. Barnabas Healthcare System. I worked up in Bergen County. I had all the alphabet courses to be an instructor. I was a professor at the George Washington University. I had the opportunity to work for the Pan American Health Organization on on a book and on EMS in the Bahamas. And I also did the EMS system redesign in Hong Kong. I'm a nurse and a paramedic, so I spend most of the time arguing with myself. And and I've been. I don't know whether it's luck or what have you. I'm out in California now. I was the acting EMS director for the city of Oakland. I am the EMS coordinator for the city of Alameda, and I sit on federal committees. I sit on the Public Safety Council for NIOSH, and I sit on another advisory committee for NHTSA EMS. And I've been extremely fortunate again, to meet people like Dan and Ed, and I would say I'm blessed. I'm saying I'm blessed, and I've got to work with people here in the United States and around the world on a variety of different projects. And if I wasn't busy enough, I'm like working on my doctorate right now. So,
well, not bad for a guy from Jersey, huh?
I got here with a public school in New Jersey. I went to public
Catholic school kids. So sorry.
You can spell. You could do all the important things.
And yeah, absolutely. The nuns made sure of that. So interesting career from somebody who started out as an EMT, went to paramedic. You've had the chance to see a lot of things. You've got a lot of years in the business. And I think that's where we wanted to go with this episode today, is we start talking, and this is kind of the culmination of us kind of talking and passing at conferences and what have you. Dan, I've noticed, I'm kind of getting up there. I've been a medic probably about 20 plus years, pushing 25. And I've noticed my partner's significantly younger than me now. I've got less days ahead of me than I do behind me at that point. I'm not ready to hang up the stethoscope, but I've graduated from that, that nervous student to that seasoned, past the seasoned into the senior medic role. And it's kind of an interesting place to be because in our society, it seems like, especially in the world of EMS, there is definitely a dichotomy between the younger generations and the older generations. If you go on social media, and who in EMS doesn't nowadays, there are a ton of things with the quotes of boomer medics, talking about the old dinosaurs of EMS who, for whatever reason aren't current or aren't up on things. And, I wanted to get your feeling for that because I'm kind of like, I would watch these things and I'm kind of like, that's not me. I don't know who that is. I mean, I know there are some people like that, but I don't think we're all like that. And I think for the younger generation, I think they're missing out on an opportunity here. What do you think?
I'll tell you that when I first became a paramedic,
Mm-hmm.
there were guys that they were still practicing ACLS and still doing things that, like they did 10 years before. But they were a minority. But then there were always those senior medics that you looked to that were always up on the latest technique. They were always well read.
Mm-hmm.
And if you stopped and you paid attention and you asked questions, and maybe like not in the middle of the call, listen, let's control bleeding right now. We'll talk about this later on, right? But
Yeah, definitely.
but if you asked questions after the call, or if the guy was kind of in tune to what was going on around him, they would, if you didn't ask questions, they might take the opportunity to educate you. And so I don't think that this is a new phenomenon. I think that what it is that, we are more acutely aware of it because, when I was in the field, I tended, for that first year or so, you kind of keep your mouth shut. You're
Yeah,
kind of
definitely.
figuring your way around and everything like that. But now, all bets are off, and there's very little reticence to, voicing your opinion or saying what you want to say. And so I think now we're just more aware that these ideas or attitudes that are out there. I think the question that we need to ask is that, is this really the majority? And I don't think that it is, as opposed to, it's really a minority of medics. I don't think that the new guys, I mean, it's funny. So I'm here in California. I'm the EMS coordinator for the city of Alameda Fire Department. And for my guys to get county accredited, like I have to ride on the ambulance with them and I have to sign them off and they have to meet benchmarks and the whole 9 yards. So at the end of their probationary period, like I am out there with them and we are going on calls and, and we are, we are taking care of patients and, we're doing everything. And, I have guys that, tell me, my shifts with you, I've learned so much more
Mm-hmm.
than I've learned in paramedic school.
Wow.
So, I think that, we probably need, I mean, what I would personally like to see is like every new EMT, every new paramedic gets a mentor. And it's somebody that has, and not somebody with 5 years. I'm talking about a guy that's been there 10 years.
Mm-hmm.
And they have the clinical chops and they have the institutional memory, and that's what I'm going to impart to you. This is there's a reason why we do this like this, and this is the reason why.
Mm.
These are the things, you're going to the trauma center. This is what the doc wants to hear on the radio when you give your bedside report. This is what they want to know. Car accident, gunshot wound doesn't make a difference.
No, I think that's a really good point. We tend to live in this hyper polarized social media based world now where, people are making these snap decisions on the internet and everybody's getting painted with a broad brush, whether it's, and millennials get this too, right? They get this, oh, they're not interested. They don't care. They don't want to put the effort in. And, we've talked to people, we had an episode about this with Tyler Chris Foley way back. It's not necessarily that. It's that they just want to know things in their way, and they want a little bit of tailoring to what they're used to and how they respond to the world around them. I don't think that's unreasonable. But I do think that we need to break down some of these barriers between the real senior people and the new people, or the up and coming, the hot shots, so to speak, where you can learn from them, like where you can learn things from them. And I think there's a lot to learn. especially again in this computer-based iPhone reference look it up type world. I think there's a lot of things that the older medics do and did and continue to do that they can impart that younger medics can pick up on that and put it in their toolbox. What are some things that would come to mind for you that you think that older medics do or did that you don't see the younger generation doing as much, but they could benefit from it?
Well, one of the things, I mean, let's speak like from the patient dynamic standpoint, first of all. And I see this a lot, especially with the newer individuals that come in. They're very cold
Okay.
in their interaction. And it's critically important to establish that rapport because you don't want to find out at the hospital there was a critical piece of information that would have been key to your assessment and the patient pops it loose to the doctor or the nurse while you're giving a report. And we've all been in that situation, okay? Where, we've asked patients like multiple times, like, hey, look, are you taking any medicine? Are you taking, and then you get to the hospital, the patient turns around and says, well, I take insulin.
You're like,
well, I didn't think that was a medication.
right.
We've all been in that scenario. But, patients kind of key on that. And so, learning interpersonal dynamics, working with patients, working with their families. I mean, I used to work with some guys that you knew that as soon as you walked in the door, you were going to go to war with the family because, just because of that person's attitude, right? So, that was, that just worked totally against you. So, the first thing is the interpersonal dynamics, and not only with patients, but with other first responders, police department, fire department, BLS agencies, SCT, whoever you're working with. And establishing that rapport, because that might be easier for some people. Some people are like really, really personable. You meet like that new kid and like, hey, I love this guy. He's really nice, etc. But for some of them, they spend all day on the phone. They're on their social media, and that is their level of interaction with other people. And sometimes you'll arrive at the emergency department, and I had to sit down with one guy and have like a really in-depth discussion with him about how he treated the ER staff. Because, and this was like a small emergency department, and he kind of like looked down at them, for what they were doing. And I said, hey, look, dude, you have to put this in perspective. Like we're not talking about like UCSF, like this giant hospital, that has all these resources, etc. This is a small community hospital. And, they're not used to seeing the level of acuity that we normally see. So, you need to dial it back a little bit. And remember, it's all about the patient. It isn't about you, and it's definitely not against them. You don't want to set something up because that can impact the patient as well. If that nurse or doctor has a negative experience with you, that could reflect against the patient, and that's an important, that's an important thing that I like to impart. The other thing too is like the physical exam. How you broach questions. Like we always ask the question, we'll press on somebody's having chest pain. We'll press on the guy's chest and we'll say, does that hurt? And then say, okay, well, chest pain's reproducible. And that's really not the question we should ask. Like I try to tell guys all the time, when you press on somebody's chest, ask them, does this feel like the pain that you're having in your chest, or does it feel different? And that's a different question.
Right.
And so now you're going to get a different response. When you go to the hospital, you have incredible opportunities, especially when you go to the trauma center. So I worked at UMDNJ, and Ken Swan was like this rock star trauma surgeon who was like a doc in Vietnam, and he jumped out of helicopters and all this other stuff. And, he taught me how to diagnose a pelvic fracture with a stethoscope. And I'm not going to go into the details here. I mean, you could find it on PubMed.
Okay.
That's something that I have taught other people over time, and it's not ironclad.
Right.
But like, it's a clinical skill, that you transfer. That transfer of knowledge over a period of time is so critically important. And the interactions that I have with the younger medics now, I try to, my approach to QA is not punitive. Like, one of my jobs is I'm the QA coordinator.
Lucky you.
So my job isn't punitive. My job is educational. And I have guys that come to me all the time. I mean, this weekend I had people call me. It was Sunday. I was, and I was like typing a letter to my cousin, and one of my guys called me up and is like, "I have a question. I'm here with a patient, and they wanted to like tap into my level of expertise, which I'm, like, that's what I'm here for. That's what I'm there for. And so, that transfer of knowledge, and hopefully, like what I told that guy, he teaches somebody else, right? That's what we want to happen, right? We want it to go out.
Yeah, definitely. The thing that always impressed me with the senior medics when I was a student and coming up as a young guy was, again, you touched on it with the idea of the stethoscope for the pelvic fracture, which I've heard of, I've read about it. It does exist. I'll put it in the show notes, I promise. It is bananas, but it might work, and especially in an austere environment, or if you're a wilderness guy, this might be right up your alley. But the thing that impressed me was when I started, and when we started, like, I think that we didn't have all the tech tools. We didn't have all the bells and whistles and the computerized stuff. Our monitors were very analog. I started, we didn't have 12 leads. We didn't have pulse oximetry. You had to basically, the thing that I picked up with the senior medics was that, the two things that I really always got from me, and maybe you can talk about, is, first of all, their powers of observation. They may be slow. They may not move as quickly as their younger counterpart. I know I don't move as fast on a call as my partner does. That might have to do with her caffeine level, but whatever. But there was an observational thing that they were able to pick things out. And you would go with like some of these senior medics, and they would know almost right from walking in the door what they were dealing with. And you'd be like, wait a minute, how did you do that? Like, how did you pick up on that? So I think the observational things were there. And just like with the stethoscope on with the pelvic fractures, your physical exam skills, things that I don't see anywhere, like palpation, like putting hands on a patient, I would see them do that, and they would get tons of information, and so much that they would be able to really do a great job on an exam without the bells and whistles that we have, without all the leads and without all the capnography and all the, which is great. I love it. I love all the toys. I love all the stuff. But those two things, I think, are really things that are really cool that the senior generation did. And I think it can be imparted to the younger generation. What do you think?
Oh, absolutely. And the best example, you mentioned 12 leads, and I'll give you the example, right? So inferior wall MI, we don't give nitroglycerin. Oh my God, never give nitroglycerin. So before 12 leads, I didn't know if you were having an inferior wall MI. I couldn't tell you where your MI was. Like, I'm looking at lead 2.
Right.
This is all I know. And lead 2 was like on the Life Pack 5, if you're old enough, or the Life Pack 10, was not in diagnostic mode. I think the Life Pack 10 had a diagnostic mode button.
Yeah.
You could hit on it.
But I had to learn modified chest leads. I was like,
But it was in monitor mode. So how do I know if you're an inferior wall MI? Well, that's not the standard, boys and girls. We go by blood pressure.
Okay.
That was all, like, that's what we taught people in the very beginning. We taught ER doctors learn that, nurses learn that, paramedics learn that, and if you have a good blood pressure, nitroglycerin was a safe drug to give. But, when you started getting to numbers below 100 and you started brushing up against 90 or lower than that, maybe nitroglycerin wasn't the good
Right.
thing to give. And so here, one of the things that we did, I taught I've taught my medics this ad nauseum, so much so, like one of the things that they've done here over a period of time was like they removed that section of the policy, and it was like, use blood pressure to guide your clinical decision making about whether to administer nitroglycerin or not. And even with that caveat, I have guys that we do ACLS with, or I have guys that I do a field ride along with, and they kind of look at me with reticence about administering nitroglycerin. And, I just have to kind of like rein them in a little bit and just do more focused, education while we're there, right? But, we gave nitroglycerin forever, and we didn't know if the guy had an inferior wall MI. Blood pressure was our guiding tool. And it's just like pulse ox. Pulse oximetry is a great tool. What was one of the things we learned during COVID was that if you were a person of color, all right, your pulse oximetry reading was not accurate. And we had so many people that we sent home with pulse ox units, and we said, when you get to this number, you need to come back in.
Right.
Well, sometimes we would get people that never got to that number, but they were in such respiratory distress. We would get them, bring them back in, and lo and behold, their blood gas was in the 60s. I never heard of anybody with a blood gas in the 60s that was conscious.
Right. Yeah, the happy hypoxics.
And, that idea of treat the patient, not the monitor.
Right.
Is so critically important. And it's something that I don't want to say that we harp on, but it's it's one of our guiding principles, that we impart to people. And I don't know, like part of the thing is, like when I first came up, when I first became an EMT, you put somebody on a backboard if they had a back injury, right? Like that was the thing. And at some point, like EMT started to float into the system that they had a guy with a gunshot wound in the belly and they wanted to put him on a backboard. And I said, we're not going to do that. And they was like, well, we don't know where the bullet went to. I was like, that's why we're going to bring him to the trauma center. They will figure that out. But we're not going to put this guy in a backboard. Like we're not going to take that time.
Okay.
But this became an idea that somebody with the best intentions said, maybe this is what we should do. And there really wasn't any clinical evidence to refute it. And so, there were some old timers who were like, no, I'm not doing that. I'm not putting the guy on a backboard. But some places made that their clinical protocol. Like, we're going to put everybody on a backboard with a penetrating gunshot wound or a knife wound because we don't know where that went to.
Okay.
And common sense, kind of went out the window there. And we see that same thing with junior members. So if you remember, for time immemorial, they would sandwich a patient that was having a mental health crisis between like two scoop stretchers.
Yeah, no.
Right? And so
no.
That was like an acceptable, practice. Or they would crisscross the patient's arms and restrain him. Again, not an acceptable, not an acceptable practice. And so, the senior medics, like I said, like guys like John Avery and Michelle DeAndre, people like that, like, no, don't do that. That's extremely bad. And this is the reason why, And so sometimes, you get on scene and you have to untie somebody and restrain them in the right way, and then try to teach people. I don't think that this is so I don't think that some of this is a new phenomenon. But I think that what it is, it's a continuation of this thing of, well, this is what I did, and it's not nothing bad happened, so this must be the right thing. This must be the right
Right.
thing to do. It's sort of like the gentleman, I can't think of his name, Elijah McClain.
Yeah.
And when I think about that when you talk to people in that system, it wasn't something that was ever an issue before, of acquiescing to the police department to chemically restrain somebody and or giving a higher dose of ketamine. It was like an accepted practice over time. And I think in those situations, that was an opportunity for the senior clinicians in the department to turn around and say, wait, no, this is not the right thing. This is not the right thing to do.
Normalization of deviance and, rigidly following protocols without an understanding of, the whys. And I think that's something else that the senior medics are very good at, is the whys and the understanding of the subtleties of things. Just like one of the things that I learned when I was a brand new medic student was I had a preceptor told me, you know what? Whenever you're dealing with a patient, when you go up to them, go up and introduce yourself, get a radial pulse, start talking. Because you're going to get heart rate, quality, rhythm, you're going to get skin color, temperature, you're going to measure their alertness, you're going to measure the verbal response. You're getting 10 assessment parameters in the first 15 seconds. And it's such a simple thing. And, before the age of, we put the pulse ox on, we put the monitor on, we put the multi-mode thing, we put the capnography on. That was what you did as a rule to kind of get yourself like, hey, do I have time here to talk? Or do we have to really do stuff? Is this something that's bad? That's something that I've always taken with me. And it's the things like that, I think that for the younger people here, that if you talk to some of your senior people, your senior EMTs, your senior medics, your senior, nursing staff, they're going to be able to tell you some of these old, these old ideas. They're not so old and out of date that they can't be modified or used in this world and make you a better clinician.
Oh, I absolutely wholeheartedly agree. One of the things that I always do, that I still do to this day, is that when I walk into a patient's room, I might talk to them a little bit. And the first thing I say to them, like, I might touch you in a couple of different places here, but, I'm listening to you. And one of the things that I always do is I pop the sheet back and I grab their foot and I look at their toes. And if it's a normal temperature in the room, okay, like if we're out on the street, obviously that's not happening. But
Sure.
if I'm in somebody's house and the room is like normal temperature, right, 70 degrees, 72 degrees, and I reach down and your toes are cold, then the next thing I want to look at is your color. Because realistically, you should have good perfusion down there. Now, this might be a ongoing problem, like your feet are always cold, but like if they're like a little mottled or cyanotic, that's kind of telling me that you have like a circulation issue that's going on here, and you're probably under oxygenated. And I can't tell you like how many times that I've gone to convalescent homes, or even residential addresses. And I found that, and I will say to the EMT, do you know why I did that? Like after the call, do you know why I did that? And then and that kind of opens up the opportunity for a dialogue, about like little clinical pearls.
Yeah, and I love things like that, and I love people who get into the physical exam and really interact with their patients. I think that's the essence of paramedicine, and I don't think that essence has changed from the days of from Roy and Johnny on Squad 51 to wherever we're going next with Whole Blood and hovercraft and cyber trucks. I don't know. It's going to be all nuts by the time I'm gone. But This was great. For the younger people here, before we break, talk to your senior people. Go get a cup of coffee, go get a soda, iced tea, whatever. Sit around with them. Identify the ones that that are actually doing the job and enjoy doing the job, and talk to them. They're going to give you some interesting ideas. They're going to give you some interesting things. Some of the stuff may sound weird, but it doesn't necessarily mean that it's not completely off the wall. So for the younger students, and the younger clinicians out there, talk to your senior people. It's not just their boomer medics. They may actually have some really important things for you to contribute to your toolbox to make you a better clinician. And that's really what we all want to do at the end. We're going to take a break right now. We're going to go, we'll be back with Dan Gerard in just a minute.
Hey everybody, it's Ed, and I want to tell you about the Monday Afternoon Journal Club. It's a new thing we've been doing on the Overrun here on YouTube, and we're really excited about it. We've gotten a lot of really good feedback for it. What we're doing is we're taking new journal articles that have been published within the past year, 6 months, 3 months, and sometimes even the past couple weeks, and updating you about new EMS information, whether it's clinical care, response times, operations, all of those things. We're bringing you the newest EMS data. So subscribe to the Overrun on YouTube and check out the Monday Afternoon Journal Club most Monday afternoons. Now back to the show.
Hey everybody, welcome back. We're back from break with Dan Gerard, Jersey medic, nurse, paramagician, whatever. Somebody that's been in the field for a long time with a lot of wisdom. Dan, we were talking in the first group about senior medics and the value that they can bring to you as a clinician. If you're willing to open up and listen to them and learn as a young clinician. I want to go into talking to you about this article you just wrote that's in Journal of EMS in GEMS about emergency medical services being a human right. This is a pretty provocative topic. It'll be up in the show notes for everybody. I think everybody really should read this because I think it's a very important topic now, especially as we're concerned with EMS getting stretched out. And, there is a worry about overutilization of the system, and we complain about frequent flyers. But I think you're onto something here because we really have to start thinking about EMS and pre-hospital care as a whole, not as something that's a privilege, but it's something that everybody needs and everybody deserves to have. So take us through how did you come up with the idea for the article? What's some of the main ideas and what do you want to get across with it?
Well, Dan, this really all started from discussions regarding, EMS as an essential service. And there's only like 23 or 24 states that recognize EMS as an essential service, that they actually say that. And it was infuriating. I was like, what do you mean it's not an essential service? How could it not be an essential service? During COVID, we turned around and we said, like grocery store workers were essential service. Mm-hmm. All these things were essential service. The plumber was an essential service. Like, how's the plumber an essential service? EMS is an essential service. But then, I had to, it's like layers of an onion, right? You have to peel it back a little bit to kind of get to the center. And so as I started to peel back, it's like, well, for it to be an essential service, there are organizations that say, well, EMS is a common good. And, that kind of stunts the description of an essential service. Mm-hmm. And realistically, EMS is a public good, right? It's non-exclusionary. It can't. It's government provided either as a contract or as a provision of the government, right? So if you go up to Boston EMS is provided as a provision of the government.
Right.
If you go to Bayonne, it's McCabe Ambulance, right? It's a contracted service. Right. There's no rivalry there. Like, this isn't the Mother Jugs and Speed time of the EMS business. and it is essential to the safety of the community. So it has the same import as the police department, the fire service, and even national defense. But if you peel it back even further, in order to say that it's a public good, you have to say it's a human right. And if we look at the provisions of guys like John Locke, right? Everybody's heard the term life, liberty, and the pursuit of
Sure.
happiness. And Thomas Jefferson, like, has been taking credit for that forever. But realistically, those were ideas that were imbued from John Locke, and he was a
Right.
philosopher in England. And so, Locke's philosophy of life and liberty is something that's essential to a human right. And when we look at it, it is those essential rights that are enshrined in things like when you look at the Geneva Conventions, or you look at the UN documents on human rights. When there's a war that's going on, combatants have to provide medical care not only for their own people, but for enemy soldiers, and also for the people of the area that they're fighting in. So when we sent our forces into Germany in World War II, for example, we not only took care of U.S. servicemen, we took care of German servicemen, and we also took care of the civilian populace that was injured along the way. And in some instances, we made it easier for the International Red Cross to come in and set up hospitals, etc. So there's a long history of this. And so, one thing feeds into the other. If you realize that healthcare and EMS by extension is a human right, then you also realize now that it is a public good. And it is something that the government provides access to. And then it automatically goes into that it's an essential service, and it's quintessential to what we need to do in our communities every day. And if you pose all three arguments to leaders in government, in public health, etc.,
Mhm.
they're like, oh, okay, yeah, like, this makes sense.
Yeah, it makes sense. But in reality, what we have now is we don't have that, right? We have this kind of patchwork mishmash of some places have it, some places are government supported through tax money. Some of them are of the idea that they can pay for it through billing, which we can get into that's a whole nother thing we could get into. And some places are underserved and some places aren't served at all. So we really don't have that yet in the US, do we?
Oh, no, not at all. But if you think about it like this, EMS is a fraction of 1% of the GDP spent on healthcare in the United States.
Interesting.
You can easily the cost to provide EMS is the rounding error for expired drugs, okay, across the United
Wow.
States. Okay, so you could easily pay for it. Like, if all the healthcare systems in the United States got together, they could kick in some money. They could provide free EMS across the United States. It would it would be it would be the easiest thing. It would be the easiest thing for them to do.
Or
But
conversely, you could pay $20 on your property tax a year and make sure you have ambulances with trained people that'll respond in a certain amount of time, that you don't have to depend, well, I hope Dave's home today, so when the whistle goes off, he's going to be able to get the ambulance. You could actually have this kind of professional service. And again, if we think this is an important thing in wartime for people involved in fighting, like, why are we not doing it today? What's the holdup, do you think?
well, if you look at the formation of EMS over time, the first two EMS services in the United States. One was the Cincinnati Hospital was first, and Bellevue Hospital was second.
Yeah.
But by and large, across the United States, it was like this hodgepodge of providers. And some of them had training. So, like when you went to Ohio, they actually had a very robust training program for ambulance attendants. But it was well more than what you got from taking a standard Red Cross first aid program. And they covered extrication and childbirth. They covered all the things, and really became the model for the basic EMT program. But then you had some places where you showed up, the ambulance service was provided at a funeral home, and you were essentially just taught how to lift and move bodies. And when you weren't, if you didn't go on an ambulance call, you might go to St. James Hospital and pick up somebody and bring them back to the funeral home, to prepare them for delivery. But I mean,
Right.
that's the God's honest truth. And so, we had this hodgepodge of delivery models across the United States. Some services were paid, some services weren't. Some were hospital based. Some were, based in the police department or the fire department or the public health department. And so, over time, how the service was paid for was really not conceptualized to the degree of what the future would hold.
Mhm.
It was essentially based on, what are we paying these two guys to staff the ambulance? And roughly, what are the costs for the sheets and everything else that we need to move them from point A to point B? I mean, there were a few places that gave oxygen, that carried oxygen, but people considered that a negligible
Right.
cost. And realistically, like, they would just take the oxygen mask and they would probably just wipe it off and then you reuse it again, right? Like that went
Oh
on.
yeah, I remember those days.
Yeah. Oh yeah, sure. That went on for decades. I the big issue, the change came about, with this idea that EMS was a business and we could generate revenue from it.
Mhm.
But I'm always leery of these things. Like when I see an ambulance service that gets the EMS contract for a community and they zero bid it, I'm always concerned about that because the community has zero skin in the game. It's not costing me anything. I get this for free.
But you don't.
And as long as well, and as long as the ambulance shows up, like, what do I have to complain about?
Right. Until the bill comes.
Until the bill comes. But that's on the individual. That's not on the city that contracts for the service.
Right. But if it's an essential good, I guess that's where I'm getting at, and here comes my liberal side coming out. So, Republicans, feel free to fire at me. Come at me in the comments. I don't care. If it's an essential good and it's a public good, are we saying we should just bite the bullet and publicly finance this and just be done with this?
We should, and we should look at how we can leverage other resources, one, to decrease costs, but also, I'm not saying that we shouldn't bill, but it shouldn't be like a $2,000 bill to insurance. Like, if you have insurance, you might charge your insurance like $400 to offset the cost of the service. The problem that you run into is that no community is homogeneous, and even communities that are right next to one another. And we could point to any community in the United States, but especially, in New Jersey, if you look at one community, it might be very affluent and it's right next door to a very poor community.
Yeah.
And so, there isn't that base of reimbursables that can offset the cost of providing the service. And the people that are socially and economically disadvantaged generally have greater utilization of EMS because EMS is the healthcare provider of last resort. I can't afford my medications. I can't take time off from take time off from work to go to the doctor because I don't get any sick time. and I won't get paid for that. And so what happens is they have an urgent or an emergent condition, and they default to EMS to provide care for them, and they ultimately go to the emergency department. But again, these are all costs, that don't get recouped, that don't get paid for. And so we can envision a system of care, where, we're going to charge insurance, but the taxpayers have a responsibility to provide this service, and they have skin in the game, because now we're going to talk about, do we have enough ambulances? Why did the ambulance take too long to get there? In your town, if the crime rate goes up, they're going to have a city council meeting. They're going to put the police chief there, and it's like, why is crime going up?
Yeah, sure.
Why are all these houses? And if they don't like the answer, what happens to the fire chief?
Mm-hmm.
He's tout de finute. He's out the door.
Right. Yeah, absolutely.
It's the same thing with the fire service.
Right. And I think people have missed in this world. I think we were talking about this before we started recording. I think we've got this idea in society today, again, that all taxes are bad. Any kind of taxes that are levied on you are borderline, an affront to your constitutional rights. And, we forget the whole idea of, hey, we're all chipping in to make our community better. And, it's like no different than, you like roads. I live in New Jersey. I love my snowplow guys. I love them when they come down, when the county comes down my street, because I know I'm going to be able to get out later and go get my bread and milk, right? I like my schools. I like my, I like my water. I like the guys who, make sure the traffic lights work. I like, and yes, when I have a fire at my house or I have a problem, I love calling 911 and having a ton of trucks pull up with a bunch of guys who want to take care of the problem. And I'm willing to pay for it because I pay for it every year, and I don't even notice it.
Well, and so here, let me give you the record.
And just for the record, I've never had a fire at my house. I've never used the fire department. I've never used the police department.
I don't know if I mentioned it, but let's look at the insurance example. Mm-hmm. So my neighbor called me up, and she said, "Hey, listen, can you come over here?" And I knew your mom was sick. I was like, "Is your mom like? Do we have to call the ambulance? Like, let's call now before I come next door." Yeah. And she's like, "No. From my mom's last trip, will you help me understand the bill?" I said, "All right, look, I'll try to help you." Mm-hmm. And I went over there, and she was pointing at different things, and she's like, what's the cost of this? What's the cost of that? And then she pointed, she's like, "Why did they charge me $12 for an aspirin? Why did they charge me $12 for an aspirin?"
Good point.
And this is like one of the largest healthcare providers in the state of California, and I'm not going to say who it is, sure. But they charged her $12 for an aspirin, and an aspirin, realistically, costs like 2 cents. It's like 2.3 cents or something like that. That's what an aspirin costs.
Listen, I'm just going to say, if you can make it in a college organic chemistry lab, it ain't that expensive, folks.
Sure. And so, but there's this cost shifting that goes on. Sure. So she's not only paying for her aspirin, she's paying for the people that can't afford the aspirin. She's paying for everybody else that can't afford care in the hospital. So think about it like this. You can point to certain communities across the United States, Boston, Pittsburgh, etc. They are well prepared. They have excellent service. They have excellent level of care. Mm-hmm. They have the things that they need for their community. Do they need more ambulances and they need more personnel? Absolutely. But we're not, in regards to readiness, the community, the taxpayers pay for that. Mm-hmm. But if you point to a poor community, and I'm not going to name a specific city, but if you point to a poor community and they don't have any of the readiness things, they don't have medical priority dispatch, they don't have the things that they need in case that there's a disaster or a mass casualty incident. They don't have in-service training. They don't have the not only the the basic equipment, but the equipment that you need above that to provide high quality care. As if you're going to charge me as an insurer, why do I have to pay for somebody else if my community is already prepared? It's almost like it's a stealth tax that we have no say or no control over.
Right.
And it's something that there's no transparency to it whatsoever. So when you charge me, if I call for EMS and and my copay is going to go from $200 to $400 for my copay, what is that $200 going for? And is it going to pay for other communities that aren't prepared? But now, if we bring it under the auspices of the government, there's a degree of accountability. And it doesn't make a difference to service delivery model. It could be the fire department, it could be a private service, it could be a hospital-based ambulance. It doesn't make a difference who's showing up. I'm the taxpayer, I'm paying for it. Where's the sugar for my dime? Show me what I'm getting by paying these taxes, and there has to be a degree of transparency.
And you get that with that publicly funded system, as opposed to this kind of, I love the idea of the stealth tax. Like, I had a guy, older guy I used to work with who, when we would talk about buying equipment or something, he would say, buy once, cry once. And the idea was, you buy once, you buy the quality, you put the money into it, and it pays off in the end. You don't buy the $10 boots because they're going to fall apart every year. You buy the $50 boots because those boots are going to be there 10 years from now. And I think that's where we're going with this. If, like you said, and you've made a really good case with this, I mean, to the point where I had to go back to some of my college poli-sci books to look at John Locke again. But, if we're doing this, and we realize in the end we're paying for it anyway, right? Don't we want to pay for quality? Don't we want it to matter? And don't we want to have the best possible outcomes? Even if that means that, yes, in some instances, you will pay for something you will not use. And okay, but that's part of the greater good, right?
Listen, Dan, nobody picks up the phone and says, I live at 186 Harrison Street in Bloomfield, New Jersey. And that was my mom's address. I live at 186 Harrison Street in Bloomfield, New Jersey. My mom is having a heart attack. And they don't end the conversation with, send the two best people that you have. Send the best equipment that you have. Send the best ambulance that you have. That's the expectation. And everybody deserves that. They deserve the best law enforcement. They deserve the best fire service. They deserve the best EMS service. Because at the end of the day, if somebody lives or if somebody dies at the end of the day, or somebody has a poor outcome at the end of the day, you don't ever want to second guess the decision that you made to utilize that service, because you really didn't have another choice.
That's a fantastic point. That is something that probably should be, written down and saved and brought out at every council meeting, whatever you want. I think that's a great way to end it. Dan Gerard, friend of the show, I think it's your second time on. We hope to have you back because I know you and I were talking about, we've got another thing we're going to do that's probably going to cause some drama, but that's down the road.
Okay.
But I want to thank you for being on. Thank you for the wisdom. Thanks for being a part of the, keeping things going and, trying to make EMS better than where we leave it. Really, it's really important stuff. It's stuff that everybody should definitely read. I'm going to link to the article in the show notes. It's a very powerful argument for why we should probably start thinking about changing how we've been doing things. So,
and Dan, let me say, you and Ed are doing some fantastic work, and I appreciate everything that you're doing in the space for the profession.
Great, we really appreciate it. We're still having fun with this. I'm going to do it as long as it stays fun. So we're going to, keep getting out there and keep letting people know what's going on, and hopefully have you back on soon to talk about some other stuff. So for Dan Gerard and Ed and the rest of the Overrun gang, I'm Dan Schwester. Check us out everywhere on social media. Check it out on YouTube, on TikTok. Yes, we've done that. Like, follow, subscribe. It's a button somewhere over here. Ed tells me I can't see it either. Also our Facebook, conference season's coming. We're going to be out at some of the conferences. We'll talk about that in the near future. But for everybody, thanks for listening. Have a great shift, and get home safe. Take care.
Bye-bye.